I graduated medical school from the University of Jordan in Amman, Jordan, and then came to the United States for training. I did my internal medicine residency as well as my medical oncology and hematology fellowship, plus an additional fellowship in breast oncology here at Baylor College of Medicine, Duncan Comprehensive Cancer Center, where I then joined the faculty and served in many roles. And currently, I am a professor and executive medical director of the Duncan Comprehensive Cancer Center at Baylor. My research focus is translational clinical trials based on my laboratory and clinical research background in ER positive and HER2 positive breast cancer. Both those subsets I've done work on and developed or helped develop many biomarkers related to response and resistance to targeted therapies in breast cancer. You see, when you're talking about any cancer cell, what you are looking for is the pathway or pathways that are driving the tumor's growth and aggressive behavior and proliferation and metastases. And in HER2 positive breast cancer, which is about 15 to 20% of breast cancer, the overexpression or amplification of HER2 is a major driving pathway. Interestingly, when the tumor is also positive for the estrogen receptor, ER, then you are providing the tumor with another pathway for resistance. And we've actually demonstrated in preclinical models and on clinical samples that if you inhibit the HER2 pathway, the ER expression and the ER function could go up, thus functioning as an escape route or escape pathway for resistance. So many people feel that the absence of that ER expression, and with it, of course, the transcriptional programs that could change the signaling of the tumor from a HER2 enriched into maybe a luminal type tumor, then that actually could basically be a reason for less response. And that's been seen in many studies. We've actually demonstrated that if you target ER in addition to anti-HER2 therapy, you actually do improve those outcomes. So it does seem that it is really the signaling of the estrogen receptor that's driving that partial resistance to anti-HER2 therapy and really interfering with that pure HER2 oncogene addiction that we like to target and enhance the response to. Many people have, tried and continue to try and look at markers of response and resistance in HER2 positive disease and many others. For example, in HER2 positive disease, I think one of the major pathways that we just discussed was the estrogen receptor, as that could actually, even if not initially part of what drives the tumors, once you inhibit HER2, ER could start getting upregulated and could start becoming a pathway of resistance. So that's one pathway. The PI3 kinase pathway and mutations or alterations in the PIK3CA gene, or even arguably others proteins along the pathway, could result in essentially turning on that downstream signaling pathway, regardless of what happens at the receptor layer. And that is a pathway that is important in HER2 positive disease. We and others have demonstrated it's associated with less response to anti-HER2 therapy. And also it is important in ER positive breast cancer that's HER2 negative, because again, it is a pathway that is at least has one targeted treatments, alpelisib, and several others that are being explored in this. A third pathway of resistance in ER positive HER2 negative disease is, of course, ESR mutations. ESR1 mutations have been associated with the use of aromatase inhibitors in the metastatic setting and essentially produce an estrogen receptor that could be active in a ligand independent manner. So despite not having estrogen to bind it, that pathway could be active and resistance. And there are, of course, many other resistance mechanisms across the board in many subtypes of breast cancer that are being explored out. But these are maybe the two or three that come to mind as major pathways of resistance. PI3 kinase mutations and that pathway have been actually a very attractive pathway to study, and until the SOLAR-1 trial reported its results using alpelisib, there hasn't been a targeted therapy for that subtype of breast cancer. So patients who have a PIK3CA mutated ER-positive breast cancer in the metastatic setting have the option of giving alpelisib in that setting. And alpelisib is a new drug, and as part of its target, essentially part of its effect is that it affects, of course, glucose metabolism and then results in hyperglycemia, which can present a little bit of a challenge in the beginning to manage. But I think as people prescribe it more and more, they become more comfortable managing that side effect. There are also some dermatologic side effects that we have to pay attention to. But I think like any other targeted pathway and targeted treatment with unique toxicity, initially people are not quite sure how to manage it. And, with more experience, ways to manage and mitigate the toxicity becomes available, and people become more comfortable with it. Ipatasertib has been a drug that has actually carried a lot of promise. I think, in some recent studies, when combined with chemotherapy, it hadn't really performed that people had hoped for. But I think the most important element of a targeted therapy is how to combine it. And maybe maybe the community at large of breast cancer, maybe we need to rethink how to target molecules like ipatasertib, and whether we should really think about it in the context of inhibiting the ER pathway access and resistance to endocrine therapy and or targeted therapies associated with it. So identifying the subgroup of patients who can benefit the most from the drug and to target it in a biologically rational way is probably what needs to happen for us to discern for sure the potential of ipatasertib and many other agents. CNS metastasis in HER2-positive metastatic breast cancer is really a major challenge. In those patients, close to half of them will develop brain metastases in the course of their metastatic disease. And not only that, but despite recent improvements in the management of HER2-positive breast cancer in the early stage setting, we saw, for example, in the Catherine trial that despite that TDM1 improved, the IDFS, the invasive disease-free survival, as well as distant recurrence, it didn't really have any impact on the CNS recurrence. And so I think that's really a most important frontier, and not going to say the last, but a very important frontier in managing and fighting HER2-positive disease. And one of the ways to think about it is that what therapies cross the blood-brain barrier to treat or even hopefully in the future prevent metastatic CNS disease. And we have good and encouraging results from tucatinib in the HER2 CLAM study. It really looked like it had good CNS activity, less used agent, but still had promising results in CNS. As neratinib also has some activity in the CNS metastases. But it's not only those TKIs that can cross the blood-brain barrier. Interestingly, even larger molecules may actually have an activity. So in recent studies, although in a small subset in Destiny Breast 01, trastuzumab deruxtecan seems to have some activity in CNS disease. And of course, we need to look at larger studies and discern for better how these agents might work and whether they just work when there's gross disease that has disrupted the blood-brain barrier or there are other mechanisms at play. But CNS metastasis is, I think, a lot more complex than just the blood-brain barrier, which by itself is a challenge. I think also there is unique aspects about how the Mets find their way into the brains and how the surrounding environment or microenvironment could support resistance to treatment. So the CNS, of course, is a very important organ. And disability related to Mets in that area could be quite drastic, and therefore fighting it and being aggressive about managing it is something that we need to do better at. And right now we have a good amount of armamentarium in terms of radiation, in terms of stereotactic radiosurgery, in terms of some intrathecal treatments, as well as the small tyrosine kinase inhibitors I spoke about. But all in all, I think that's an area where a lot of research is happening because we need to do a lot better. Yeah, one of the challenging, of course, things about managing a patient with cancer is they could have other comorbid conditions that could limit our ability to use agents or make their toxicity a little bit more challenging. And so one of them is the one you alluded to with the anti-HER2 therapy. It could have cardiac toxicity, and of course we have patients who could have cardiovascular disease, which is the most common type of disease that many patients have. And what we need to do is basically, first of all, is develop a multidisciplinary team. So like right here at our center, we work very closely with the cardio-oncologists. We have a specialized center of excellence where cardiologists who are interested and have done research and training in managing patients with cancer work together closely with the oncologist about how do we first of all screen for cardiac risk factors, and is a regular, for example, echocardiogram enough, or do we need to look at the strain, which many people are thinking is playing a larger role in predicting a toxicity to these agents? And then how do we maximize the cardiac condition in a way that would allow us to give those life-saving treatments? You see, it could be easy to say, well, this person has cardiac disease, we're not going to give him anti-HER2 agents. But given how much those agents have improved outcomes in HER2 positive breast cancer, and let's not forget that it is a deadly disease, given that, we really would be hard pressed to just give up this way. So we need to reach out to the cardiologist, maximize the cardiac condition that the patients have, and then when we give them agents, monitor them very closely, be very astute in stopping those toxic agents very early on if toxicity evolves. And then importantly, when we are determining what agents to give those patients, what is the cardiac toxicity of this agent versus what we get out of it? For example, some people could be very nervous about giving anthracyclines, which have cardiac toxicity and could be long-term, versus giving some of the antibodies like trastuzumab and pertuzumab and the tyrosine kinase inhibitors that could have cardiac toxicity, but it is more reversible and more manageable. So a thoughtful approach, multidisciplinary team, and even if you are not in a large center that has those capacities, I think a phone call to the cardiologist and coordinating between the physicians who take care of the patient is very important to try and get them the treatment that's life-saving without maximizing the toxicity. COVID-19 pandemic has posed challenges for all medical care, and of course, cancer is not excluded. And what we've done is, and many others around the country and around the world, is really implement a series of precautions to, first of all, minimize the risk to our patients, with social distancing, with cleaning of facilities, and with many other aspects, masking and so on and so forth. The second is, of course, screening the patients, with temperature screens and symptom screens before every session. And of course, we developed very rapid methods to test patients who could have symptoms according to how concerned we are about their symptoms. Now, for the patients who have tested positive for COVID-19, we generally look at the treatment that's coming up versus what they have, and what is really how crucial it is for them to get the treatment versus how safe is it to maybe hold off on that treatment until they clear their COVID-19 and treat them then. And most of the time you are able to delay the treatment a few days until the patient at least recovers from symptoms. We don't require a negative test per se, but just recovers the symptoms. But that may or may not be the case. Thankfully, with the presence and the abundance of vaccine, we have encouraged our patients to get vaccinated. We've held vaccination mega clinics for cancer patients at our cancer center, and we continue to reach out even to those who are a little bit hesitant about getting the vaccine and providing them information, because the biggest protection against COVID-19 is the vaccine. And then even if they develop it while vaccinated, it's usually a mild case that they can clear very quickly. So so several complicating factors with the pandemic, but I think again with the communication with the patient and then with your other colleagues in infectious disease and infection control, I think we've managed to do it in a way that does not really impede patient care or delay it in any dangerous way, but also make sure that the patient is safe, and of course our other patients in the facility and our medical staff are safe as well. The primary care physician is really the most important physician, arguably, in screening for and diagnosing cancer. I mean, as a breast oncologist, I see the patients when they have a breast concern. They felt something or they were already diagnosed with something. Versus the primary care physician, who is really the person who's communicating with the patient, telling them that it's time to do the screening, for breast cancer, for colon cancer, for cervical cancer, and making sure the patient is up to speed on that. Just like they make sure that their, cholesterol is checked and their vaccinations are in order, they also do, cancer screening. And I think, in terms of what's available, I think, the well woman exam, for example, for women, the well woman exam, colonoscopy, of course, for everyone, or, some sort of testing or screening for colon cancer, as well as screening for breast cancer with mammograms, are available in many countries around the world, although I do realize access is not equal. But when that access is present, I think identifying the patient who are asymptomatic, who need to be tested or screened, is important. And of course, if you have anyone, a patient coming in with a breast mass, or a patient coming in with like some GI complaint or bleeding, that would actually prompt us to be worried about a cancer, or even a cancer that we don't screen for, like weight loss or a mass here or there. I think the primary care physician should then of course be alert, which I'm sure they are. And then second, I would say, if I were a primary care physician, I would try and develop a professional working relationship with some of the oncologists that I refer to, and really call them up and say, I have this patient, this, that, and the other with these symptoms. What do you recommend I do? I'm thinking to get a CT scan and a scope. Do you agree with that? They may say yes or no, or why don't you add this blood test, or why don't we get this person involved? So I think in medicine we only work in teams. None of us has all the answers, and I always I for one always pick up the phone and talk to my colleagues to try and basically get their help in working up issues that may not be along the lines of what I usually do. And I think our primary care physicians are really the people who diagnose all those illnesses. And I'm sure that many of the specialists they work with would be happy to answer questions for them, because their role is really crucial in keeping our patients healthy and diagnosing cancer as early as possible, which really can make a big difference in the outcome. I always say that being an oncologist or a cancer physician is an exercise in optimism. Of course, as a cancer physician and researcher, I am determined that we need to end the suffering of cancer, and I think that we are making progress towards that every day. And I am optimistic that a day will come where cancer becomes a treatable and curable illness a lot more than it is right now. We've made a lot of progress in many areas, but many, many more areas need improvement. But it's not going to happen, overnight. I think many people always ask, did you find a cure? Well, cancer is very complex. Every cancer is different. Every organ is different. Every person is different. And the cells that we're dealing with that form cancer are human cells. So they have all the complexity of human cells. They're far more complex than a bacteria or a virus, challenging as those are. And they are our own cells. So there's a lot of challenge in managing cancer. But it's not that we will discover a cure. We are discovering cures every day. And the future that I foresee is a future by which the individual person has an individual tumor. And then we look at all the elements that, make up that person and all the elements that make up the cancer, and tailor the best possible treatment individually to each person, to where they're either cured or their cancer is managed into a chronic disease, just like any other illness they may have, that they just control with a pill or with some routine treatment. And I am optimistic that future is not too far, and that we would make great progress. But again, it's going to come in increments over a period of time, and not in a major discovery that ends cancer overnight.